As a teenager, she'd hang out in the emergency room where her mom was working as a nurse just to see and just to watch what was happening. She knew from very early that she wanted to be a nurse. That led to a career in critical care and acute care and long-term acute care, and it also led to serious weight gain. She was, by her own admission, a professional yo-yo dieter. And then Lisa Simmons broke the code. Nurse practitioner Lisa Simmons tells us her story, how she got to be where she's at, and what she's doing to help people like me and like you get healthy, and this time, stay healthy.
He was a morbidly obese surgeon destined for an operating table and an early death. Now he's a rebel MD who is fabulously fit and fighting to make America healthy again. This is Stay Off My Operating Table with Dr. Philip Ovadia.
Welcome back, folks. It's the Stay Off My Operating Table podcast. Dr. Philip Ovadia. I'm Jack Heald, and we've got a first today. I think this is a first, maybe not. This is a first, Phil?
I'm not sure which first you're talking about. It kind of depends.
Introduce our guest, and I think it will become obvious then why she's here.
Very good. Yes, I'm very excited today to introduce Lisa Simmons to our audience. Lisa is a nurse practitioner that has now joined our practice, Ovadia Heart Health, which is our telemedicine practice where we take care of people looking to improve their metabolic health and prevent and reverse heart disease. And we are very excited that we have now expanded our clinical team. In addition to my two amazing coaches who have both been on this program, Kristen Hanks and Jen Cleveland, we have now added Lisa because we were busting at the seams, quite frankly, in terms of taking care of the people who needed our help. So with that, Lisa, why don't you give a little bit of your background, maybe tell us why you went into nursing in the first place and went on to become a nurse practitioner, and then we'll kind of get into the metabolic health aspect of it from there.
Perfect. So I have been a nurse for about 28 years. I initially went into nursing, and in high school, I knew that's what I wanted to be because my mom was a nurse. So I actually went and watched her. She used to work in an ER way before HIPAA times. And I could stand out behind the nurse's station. And at that time, there was not rooms. There was, just curtains. And so I could hear stuff that was going on. Of course, I couldn't see it. But my mom worked nights, and I was so interested in it as a teenager. When I could drive, I would go and stay up all night and watch everything that was going on just because I was so interested in it. I just thought it was great. And I just always had a passion for helping people. So that's really what got me into nursing. I always knew I didn't want to do moms and babies. So of course, my main background was critical care. So I went into ERs and ICUs because that's where all the action happens. I enjoyed it a lot. And then when I went into, nobody in my family had a bachelor's degree. So I wanted to go ahead and get a bachelor's degree in case I wanted to go to administration. So that's how that happened. And then after that, I said, I'm never going back to school. And the next thing I know, I enrolled in a nurse practitioner program. And it's just kind of how the story started. And I knew I wanted to do acute care. I just never wanted to treat children because when I went to nursing school, I had 2 babies in diapers. And I never wanted to have children be hurt. So that was never an option for me. So I went along the lines of acute care just because I could still stick with the action. And then I've done a multitude of different things to work with intensivists, and I've worked in an LTAC kind of as a hospitalist.
Whoa. A what?
A hospitalist, nurse practitioner.
What was that? What's the LTAC?
The LTAC.
LTAC is a long-term acute care. It's kind of
Thank you.
Yeah, sorry about that. So when people are they're not sick enough really to be in the ICU, but they're not well enough to go to a rehab or nursing home, and they may still have trachs. And so they may still be getting weaned off of a ventilator. So I was kind of like a hospitalist nurse practitioner there for a couple of years where I put out fires is pretty much what I did. Yeah. So I did that. And then now I've kind of graduated into things that are less stressful. Yeah. I've ran a lot of codes in my career.
I
And
dated a girl for a long time who was an ICU nurse, and one of the things I learned was that ICU nurses are a special kind of, and she worked nights as well, special kind of creature. So
yeah.
it amazed me that they could A, do it at all, but B, do it for not just years, but decades. Um,
Mhm.
so I understand why you're probably wanted to reduce the intensity of your uh, day to
Especially as I
day.
get older, less stress is better.
Yeah,
Let's help people understand what is a nurse practitioner and
yeah,
kind of
yeah.
differentiate, that from being a nurse in
Mhm.
general, and then how it fits in the care team when we're talking about doctors, physician assistants, nurse practitioners. I think a lot of people these days are used to kind of seeing all of these types of practitioners, but don't really understand maybe what some of the differences are between them.
Okay, so there's kind of different realms. If you're an LPN, you learn a lot of how to do things, but you still are under the supervision of a registered nurse. And then a registered nurse has a lot of leeway. And then what happens is now when you want to go advance past that, you go on and get a master's, or now most of them are doctorate programs where you become a doctor of nursing practice. So the difference between really a nurse at the bedside as opposed to an advanced practice registered nurse is you actually have the ability to prescribe and to actually diagnose. Nurses at the bedside don't have the ability, and it's not in their scope of practice, to be able to diagnose somebody with a certain ailment. So that's what you go back to school for. And when I went back to school, it was still a master's program, but most of them have switched over to doctorate programs. So that's really the difference between and you go, I mean, it's further schooling. So by the time you're done, it's probably about 6 years total.
Yeah, and to kind of further explain to people, nurse practitioners, as you said, have the ability to prescribe medications. They have the ability to, diagnose and treat conditions. So do lab testing, imaging, all of that. And in many states now, certainly remember when I started my career, nurse practitioners would always have to be working with a supervising physician. And now in many states, that's no longer the case, and nurse practitioners can actually practice independently.
Correct. So it just really depends on which state that you're in. Yeah. And you just have to know all the rules for all the different, and that's a lot to keep up with too. Yes, but that is very true.
So what happened going from acute care to metabolic health? That's, I mean, maybe it's obvious to Phil, but it's not obvious to me. Explain,
So,
explain how'd you get
yeah,
here?
how did I get here? So initially, when I kind of wanted to get away from stress, what happened was when I was still at the long-term acute care, I've had my own journey I like to tell everybody I'm a professional yo dieter. Pretty much, I've got it down. I've tried every diet that's been out there that you could possibly do to lose weight, gain it back, lose weight, gain it back. And I even had looked at Atkins back in the 80s. And of course, that's when they told you that if you ate protein or high protein, it was going to kill your kidneys and blah, blah, all of the hype that was around that. So I thought, oh gosh, I don't want to kill my kidneys. So I still did the Weight Watchers, the calorie counting, the eating the 6 small meals a day, exercising like a banshee. But I will tell you that you cannot out exercise a bad diet. It doesn't work, right? So I ended up about 5 years ago, I heard about the ketogenic diet. And so that's kind of how I got into it for my own journey, my own health. It was really kind of funny. I used to be one that would start a diet every Monday. And when you're calorie counting and you're doing that kind of stuff, by my snack time, I was starving because you're always doing carbs because you're counting calories. And so I was like, oh man, I was always like, I'd eat breakfast and I was like, oh, I'm going to snack because I was already so hungry. And if I screwed up by lunchtime, I would start again the next Monday. Like I wouldn't even start again with the next meal. I'd be like, oh man, we'll just start again Monday. And because you
So
always
you
start to
dieted
diet
for
on
one
Monday.
meal and just did whatever you want for 20.
Exactly. And then you wonder why you're like still at, square one, right? And so it's because nothing changes. So then what happened is I came across the ketogenic diet and I just thought, I'm really going to try this out. And I started on a Wednesday, which was like, it was totally against everything I've done in the past. So I started on a Wednesday and I got real strict and I lost 50 pounds
Holy
in a
smokes.
period of about 4 to 5 months. And so I was like, well, this kind of works. And wait a minute, I'm not hungry. That was like the clincher for me. It was like, I never thought about food anymore. Like now it was like, oh, my stomach starts to, oh, wait, you need to eat. And I would plan ahead because I have a big thing that when I'm teaching patients that they don't plan to fail, they fail to plan. So then they're on the whim, that you should already have things kind of available to you so that you're not having to stop and eat. So it was kind of, I started taking my own advice, and then how it all started down this road is I was so excited with what I had learned. I wanted to share it with the world.
Sure.
So I started meetup groups and I had 9 or 10 people that would meet with me once a week. And we would share recipes and we would talk about, hey, I'm on a stall. What do we do now? And it just kept me researching and trying to figure out like, how is this going to work the best? And it was a lot of fun for me. It was free. People could just come. And I mean, I met at a park and, and stuff. And it was really fun. And people were really interested in it. They loved it when I brought like keto desserts because that was the best night, eat the sweets and stuff. But it was just really fun and it was really good for me. And then it became just more and more of a passion because I just felt like if I knew 20 years ago what I know now, it would be like a game changer, right? I wouldn't have never had to struggle because now food to me is strictly just nutrition. When my body needs to eat for fuel, that's when I eat. The rest of the time, I never think about food. And it's just really been different. It's very different. So
what, aside from the obvious personal benefits, you've also taken a professional turn. And
I did.
And I realize I see the connection externally, but how did you decide that this was where you wanted to go professionally as well as personally? What's that all about?
I started with education. So doing a lot of things through like Nutrition Network and educating myself more on the benefits and the science of it. Of course, I'm in a science field. So I always want to know, well, why? It's that curiosity that kind of got me going down that route. And then I actually went further and got a certification as a ketogenic nutrition specialist so that I could dive deeper into the science and how really when you eat something, what does your body do with it? So that kind of really sparked more interest. And then I actually met a good girlfriend of mine that was already kind of doing this professionally. And so I joined her at a local clinic and it's just kind of gone from there on, and still educating people. So
Isn't it really different professionally doing
very.
this rather than acute care or trauma care or critical care, whatever it's called? I mean, this is wildly different, I would assume.
This is how it's supposed to be. That's what I think. We've gotten so far away from true medicine and we don't get back to the basics anymore. And when you really think about keeping your body healthy, you have to think about what are you fueling it with? What are you doing to move your body? How are you dealing with stress? And are you sleeping well? So all of those things play a key role in the overall health. And so it's getting back to really the basics and lifestyle. And what can one person do on a daily basis to extend their life expectancy without, taking a pill for this and a pill for that, and having a quick fix, but really, and getting down to the basics. Like, I wake up every day and I feel great. I sleep well. I feel good. Nothing hurts, right? I'm seeing people younger and younger, their joints ache. This hurts, that hurts. And, but they're sedentary. They don't do anything. And then they're eating, a gob of processed food, which is really not food at all. So that's what kind of keeps me going. And it's just education. It's really education and listening to the patients now, taking the time to listen, troubleshoot, and help them succeed. It is different, very different, but at just a basic level. So
I got to say, I'm sorry, Phil, from the side of a non-healthcare professional,
mhm.
I can remember the last time I saw an MD professionally, and he was wildly unhealthy. And it was just really, it was deeply troubling to have somebody who clearly had no handle on their own health telling me what to do to get healthy. And that had been my experience. So I got to believe that I'm not the only person in the world like that. It's got to be really cool for your patients, for your clients, to have somebody who struggled with the same thing and won,
Mhm.
guiding them. I love, anyway, enough with my comments, Phil. Sorry.
Yeah, no, I think that's a great observation. And, of course, we've had many medical professionals on the program at this point, and myself included, talking about that same aspect, that same concept. And of course, one of the things that I've commented on is when I was very unhealthy as a heart surgeon and as a physician, none of my colleagues really said, what are you doing? And I'd love to hear kind of Lisa's perspective on, when she was, unhealthy. And then as you made these, changes, which I'm sure were obvious to all your colleagues, you can't really lose 50 pounds without people noticing, what were some of their thoughts on what you were doing?
It was, I guess it did get their attention. So then when they started asking, that's when I had the opportunity to teach. So it was always teaching and saying, it's really not as hard as people make it out to be, and you feel so much better. I think the biggest thing is I had so much more energy. Where I was working at, it was 4 stories, and I wouldn't even take the elevator anymore. I would go up and down the stairs. I would run the stairs all day long. And I think that was the biggest takeaway was, man, I sleep well and I just have all this endless energy, and I just, because, that was more, the weight loss is great. That is great. But I think that overall, how you feel is definitely a bigger takeaway when you get to a certain age. You're like, oh, thank goodness, my joints ache, and I can get up and down, and I can get up and down off of the floor with no problem. And you kind of have to look at things as you age too. Is like, what am I doing to prevent, or things that can happen in the future, or how am I going to? I never wanted to be a burden on my children, right? So taking care of me and being able to take care of myself is definitely taking a burden off of them. So it was, hey, this is what has to happen. And now I surround myself with everybody that does the same thing, which makes it a whole lot easier. But yeah.
And, so obviously I know this, the audience doesn't, but we'll tell them, previous to joining this practice, you were working in a practice that primarily focused on managing women's hormones and all the challenges that go along with that. And, that practice wasn't a metabolic health focused practice. So kind of talk about your experience dealing with, the perimenopausal issues and what what you were maybe able to do or maybe not able to do in terms of giving this information around metabolic health and low carbohydrate diets with the women you were working with there?
Oh, I still talked about metabolic health with every single one of them. Hormones are just a piece to the puzzle, but they're not the whole puzzle, right? Every patient, when I saw them for the first time, I discussed lifestyle with them. So what are you eating? How are you sleeping? What are you doing to exercise, move your body on a daily basis? And the other one, the huge one, is stress. So I think with women, a lot of the time, I would see them and they would come and they go, I read somewhere that, I'm supposed to be on hormones because that's why I'm not losing the belly fat. That's why, I'm not sleeping at night. It's always my hormones. And it may or may not be, according to get your lab work and things like that. But to actually feel, would I say, more of quality of life and optimal health, yes, I can balance your hormones, but what are you doing? So I would always hold them accountable. And a lot of times when we would troubleshoot, like I'm still having these symptoms, my joints are aching, this is bothering me, I'm not sleeping, then I would break it down. And it always went back to nutrition, always. And I think so many people are misguided on what is the appropriate. I mean, there's one thing that makes me cringe is when people go, I eat a really clean diet, and then they have oatmeal for breakfast every day. And I just go, oh, no, you don't. And, it's the teaching. It's getting them away from everything that they've heard, or they work out with a trainer at the gym and they're still doing macros. And I have people that come in and they're eating 140, 150 grams of carbs a day. Yes, they're eating, 150 grams of protein, but they're still eating way too much carb. And then they're wondering why, hey, I'm working out, but I'm not losing any weight or even toning up. So when it comes to the hormones, yes, they benefit women who are perimenopausal. And perimenopause tends to be the hardest time. Everybody thinks it's menopause. Perimenopause is way harder on women, I think, than menopause, just because that's when the transition, your body's starting to do these weird things. And I think the biggest one that women notice is mood swings. They get really angry at the world. And for no reason, they're just like, I don't know, I'm just spouting off at my husband for no reason. And usually there's a little fix that we can do in there to help with that. But I started doing that a couple of years ago. And of course I'm postmenopausal. Don't tell anybody really, but I am. And I'm actually...
It'll be our secret. No one else will know.
But so I am a hormone patient. It did make a huge difference for me. So of course I am an advocate, but obviously you need to be with a professional that really knows what they're doing and that they're monitoring you and doing things accordingly. So there's lots of things, but they were very, very beneficial because nobody wants to have hot flashes and night sweats. I'll tell you, they stink.
And have you noticed differences in, kind of the management of the hormones in the women who, followed your other advice regarding, metabolic health, diet, lifestyle versus those that really just took the hormones?
Yeah, the ones that really listened and took my advice when it came to, okay, this is the proper nutrition. You really need to do it like this. I had multiple patients coming back going, man, Lisa, I lost 10 pounds. I lost 20 pounds. This is really working. And utilizing some of the hormones, because I did prescribe low dose testosterone for women, which helps with muscle mass loss. So my women that were really working out a lot, because I think that's another big thing that I hear about. They're not able to build the muscle mass anymore, but they also have to eat adequate amount of protein so that they can build it, right? And most people don't get an adequate amount of protein in their diet. When you start looking at that, and they're really lifting, and a lot of women they're afraid to lift heavy weight. I do find that they're doing these 5 and 8 pounds, and it's not really putting enough pressure against the muscle and the bone to really make a difference. So you're not going to build unless you're given it a little bit more. And I have to remind them that they're not going to look like Arnold because the testosterone is not as high, but it did make a difference. I had a lot of people coming back and saying that they were definitely making strides and felt a lot better when they started realizing that, you can't eat really high carb. And the misconception of you have to have carbs to be able to exercise because you need the energy. And I mean, I worked out this morning and I worked out fasted and I didn't die. And it was a hard workout, yeah. And I like it because it just makes you feel better. So.
When you say lift heavy weights, what does that mean for a woman? What's heavy weights?
When you're doing heavy weights, you want to be able to only probably get to 10 to 12 reps. And then you can't do another one. So it's going to be varied amongst different patients or different people. But when you're lifting a heavy weight, you should only be able to get to each set that you do 10 or 12 reps.
Okay.
So if you can keep going,
by how many times. It's defined by how many times you can do it.
Yeah, and it's and it doesn't even so when I emphasize lifting weights too, of course your muscles don't know what a rep is. It has no idea. Yeah. It only knows what you're doing to it till it goes to failure. So you could do 8 reps of a heavier weight, but still go to failure where you can't do one more. Right. So it's just varied on what you do. I mean, I lift pretty heavy, but I've been doing it for quite a long time. So it's varied on each individual. So I don't want them going and killing themselves because you still have to use proper form.
Sure.
So because you don't want to get injured. So making sure that when you're performing a certain exercise that you know what the proper form is, and you don't want to make, because you definitely don't want to hurt your joints.
What I'm hearing is you've got experience in critical care as dealing with people who are in life-threatening situations. You've got experience in slightly less critical, long-term acute care. Mm-hmm. You've got experience in whatever's less acute than that. And then you've got experience helping people literally just get and stay healthy. It sounds like, just from an experience standpoint, anybody who would talk to you wanting to get healthy would have someone listening who gets it, who's probably seen just about everything that can be seen.
And actually, I think working in acute care and seeing people that didn't take care of themselves. When I was in nursing school or in NP school, I worked in a CCU, which is a cardiac care unit, for 3 years while I was in my master's program. And so seeing people come in at younger and younger ages with heart attacks was really eye-opening for me. Because, I mean, you wouldn't hear, somebody in their 60s and 70s having a heart attack. Sure, that's the way it was when I started nursing, 20-something years ago. But now, we're getting people younger and younger. And it's, oh my goodness, so what do we need to be doing? What do we need to be changing that's going to prevent this from happening? And then too, taking care of people that were morbidly obese. I took care of a lot of 600 and 700 pounders.
Oh my. Ooh.
And, you can't turn that patient by yourself. You have to have 3 or 4 or 5 other nurses to help you to be able to, take care of these people. Right. So, I've really seen in this period of time just how, healthcare isn't healthcare anymore. It's more sick care. People just keep getting sicker and sicker, and they're not, what can we do to stop this? So I really feel like going back to the basics and going back to, okay, what happened 10,000 years ago? What did they do? Now, obviously people would die, right? They would die for certain reasons. I think the biggest problem back then was infections. We have antibiotics for those now, right? But convenience has really done us a disservice. because we have gotten to the point, like, we're always in a rush. Life is always on a, we're rushing here, rushing there. And, you go, oh, I'm starving, I'm going to go through the drive-through. Or, you know what, that's okay. I'm just going to pop a pizza in the oven. That's okay. But, when you really get down to what are you fueling your body with, and what does it need to actually perform the best for you? I use the analogy a lot with my patients. If you drive a vehicle that takes diesel fuel, are you going to put unleaded gas in it? No, you're not going to, because that's not what that vehicle needs to run effectively for you. So when you think of your body in the same sense, it has to be fueled with the appropriate nutrients to be able to work well for you. Right. So it's,
Sure.
and then the people go, oh, yeah, because, they wouldn't think of doing that to their vehicle. Or the other one I tell them is, you wouldn't put sugar in your gas tank, right? You wouldn't.
Oh,
It would ruin the vehicle.
You'll put it in your body, but you won't put it in your car.
Right. But the thing is, you've paid what, $20,000, $30,000 for a vehicle. You don't want to ruin it. How are you going to get to work to be able to pay for the car? But when you actually put that value on your life and your life expectancy, and in the long term, right, you have to look at now, and you have to look at, what am I doing now that's going to affect me in the future?
Sure.
So
yeah, great way to think about it. And I think the point of seeing kind of the end results of these metabolic chronic diseases really gives us insight. And I know for me personally, I think it helps. It's a very powerful way to relate it to the patient, because when I say to someone, you can deal with your insulin resistance now and eat some less carbohydrates, or I can open up your chest and deal with your insulin resistance. That's really the message that we need to be getting to people. People need to understand, in some ways, the problem we're at is we've gotten good at taking care of sick people. So people don't really worry about being sick anymore. You're like, there's medication for that. There's surgery for that. Whatever it is, it will get taken care of. And we really need to get back to, for people to understand that you don't need to be sick. It's not normal to be sick. It's become so common, that we accept it as normal these days. And, I think this is largely the message that all of us are trying to get to people, that you don't need to get to that point. We can do something about it earlier than that. And those of us in the metabolic health world, I think, are focused on doing that. What have some of the, kind of big challenges to you, both personally and professionally, I guess, been in making the changes that you've made?
Challenge-wise, I think I've been doing this for so long. Eating, for me personally, it's a no-brainer. I'm very boring. So I'm just a protein person. And I used to try to do more ketovore, and I would buy vegetables and they would stay in my refrigerator and rot. So I quit buying them. So I mainly stick with meats and eggs, and I've even cut back on cheese just because, I don't know, I just don't really need it. And I just like protein. And when I was younger, I would always eat more veggies than I would meat. And now I'm totally different, but of course I grew up before microwaves were actually invented. That ages me a little bit, but like when I was growing up, my dad would make dinner every night and they cooked it like, a concept. But then when I became a parent and I worked a lot, I went through drive-through, because it's all about convenience. And then I feel bad because I think I've done a disservice to my children, because now I'm going, no, don't eat that way. Don't do what I did.
Don't do what I did. Yeah.
But professionally, I feel like it's still an uphill battle in some realms, because I still have patients that come to me and say, my doctor says I just need to eat less and exercise more. And which is something that I, trying to go against and just get you like, no, that's not the way it is. Believe me, I've tried it. It doesn't work. And then you're hungry all the time. And so I try to get people to understand that it's really nice to be able to lose weight and not be hungry. Like, it's a concept. And it's, and of course it still takes work. And I'm still on a journey. I'm not exactly where I want to be, but I have a better handle on it. And food to me is very different, where I used to be a very bad binge eater. So if someone made me mad, I would go eat something that was really bad for me. Didn't do anything to the other person that made me mad, just did everything to me. Right. And so a lot of it is mindset as well. So yeah, you have the tools, the proper nutrition. We tell you what to eat. I tell you, like, this is how your body utilizes this. And then when we, like Dr. Ovadia goes over labs, it's, now you can see it in numbers that this is what the past years have done. Now, what are we going to do? What's going to be the game plan to improve these numbers, which is the fun part of this, because it's really doing more of something that I'm passionate about. So professionally, I still feel like it's a little bit of an uphill battle, but I feel like more and more physicians and nurses and nurse practitioners are starting to really like, oh yeah, wait, this is working. So I think a lot more people are starting to adopt it, especially if you've gone through your own journey and have, had where you've fought, weight loss or, obesity for years. And, it's like you look back and you go, well, how did I get here? I just did everything they told me to do.
Is there I want to think past the first order effects or the first order causes, maybe. Somebody comes to you and says, I've tried everything. I want to lose weight. Help me. And obviously the people who follow the guidance tend to get results. Is there a common second order cause with people who don't get results? Obviously, they're not doing what they're told to do. But is there something can we go deeper and say, hey, here's something else that always seems to be going on, or usually seems to be going on in somebody's life, that is a roadblock that keeps them from having the success they say they want to have? Does that question make sense?
Yeah, there's a couple things that I've come across. I think one that is not treated as readily as food addiction. Food addiction is difficult for some people. It's like having an addiction to alcohol or drugs, but you can, abstain from alcohol and drugs. Your body doesn't need those things, but we have to eat. So sometimes people need a little bit more help, and it might be more psychological help in that aspect. And it's individualized, obviously, because we're all N equals 1. That's just the way it is. When I'm troubleshooting with patients, a lot of them, I find they don't want to put the work in too. They'll tell me, oh, I'm doing this and this, but they're not really making any strides, or they get mad because they lost a pound in a week. And I go, if you knew how much a pound really was, or being a woman, we hate when we've lost 5 pounds, but when I tell them 5 pounds is like 5 pounds, from everywhere, then they go, oh yeah, because we think the number is so little, it should be this high number. So when it really comes to troubleshooting with different patients, a lot of them it is troubleshooting, because what works for me may not work for somebody else. So you kind of have to scale it back and either keeping a food diary and really tracking their food, or what it usually comes down to, what I've seen in practice, is they're still not eating enough protein. And so I'm, bump the protein up, right? And that's going to keep you full. And I always tell them to eat protein first, because protein keeps you full. It fills you up quicker, takes longer to digest. And then you're going to eat less of whatever else you paired it with, because you're going to get full. So you really want your emphasis to be on your protein, so that it's going to do the job it's supposed to do, which in turn is going to keep your insulin and your glucose levels very stabilized, right? So we've always heard about glucose, But now we know that it's really an insulin glucose problem. That's how we become insulin resistant. So getting people to understand that it's not, and I love it when I break it down and I tell people, like, do you know how you became a type 2 diabetic? No doctors ever tell them how they became a type 2 diabetic. They have no idea.
It just happened.
It just happened.
Yeah.
Right? And so when you break it down and then you kind of explain, this is how it happened over a period of time. And so what I love is talking about insulin resistance more than obviously diabetes, because more people in the world are insulin resistant before they ever, get to type 2 diabetes. And that can happen 15, 20 years prior to ever becoming a type 2 diabetic. Yeah. And they don't realize that the damage is being done all that time before they ever get diagnosed with type 2 diabetes. Now they have type 2 diabetes and they go, put the brakes on. I'm diabetic now, right? But if we started doing more.
It didn't happen last night.
Exactly. They think that it did, right?
Right.
But the part of it is too, is if more primary care physicians would do some of the testing, that is the simple testing, not as deep as we do at iFix Hearts, but it's more, it's so easy, just add a fasting insulin onto their blood work. I literally went and reviewed a friend's labs the other day, and he hasn't had a hemoglobin A1C ever. Like, it never was checked. And I mean, these are things, simple things that can be checked to really better educate a person and actually see where they're at. I really think if we kind of could get a lot of primary care doctors, if you're ordering labs, just order a couple extra. They're going to get their blood drawn anyway, and start really looking at these things so that you can really see, is my patient metabolically healthy? Because we all know you can carry like adipose tissue on the outside, right? And really, honestly, yeah, you have it on the outside, but you can still have, an insulin less than 10. You can still be insulin sensitive. So you don't know these things unless you start like paying attention and checking for things that maybe we can look at more prevention instead of aftermath treatment.
Yeah.
Let's talk about another kind of aspect that we do differently here with Ovadia Heart Health and iFix Hearts. And I know you have experience with this as well prior to joining us. Talk about telemedicine. Again, I think it's something that maybe people, if they haven't experienced it, may not kind of understand it and, understand the advantages of it and what we can do with because one of the challenges that we hear about most often from people is they can't find a local doctor who thinks this way, who does this stuff. And we now have a great tool to solve that problem for people.
Yeah, so I've been doing telemedicine for about 4 years, obviously, since 2020. Everything has kind of gone to that because we're kind of pushed into that. But what I love about telemedicine is the ability to take the time with a patient too. And it's convenient. For one thing, they can do everything from the comfort of their home. I've seen many a patient, they're in bed. So they're just sitting in bed or they're laying in bed and they're talking to me. I mean, you can't get any more convenient than that. But the thing is, I think a lot of people are afraid of technology, and it's really pretty simple. And the benefits of it is we can take more time. We can actually, delve into things. But I think the biggest one for me is convenience. They don't have to go and drive to the doctor's office, and, they're always late. I'm just going to say. And then you have to sit in the waiting room, and then you're waiting. And so all of this time, where telemedicine wise, if you have an appointment at 1:00, I'm going to be on the screen at 1:00. That's the way it goes. And it is easier. And so then their time, which is valuable, just like my time, is actually makes it a lot easier. Those are my ideas of benefits of telemedicine. But most of the time I get to spend more time with the patient. So that, not 5 minutes.
Speaking as the person on the patient side, it's way more important to me that my healthcare provider actually spends time with me. I have been more than happy for the last literally 20 years to go get in my car, drive half an hour to go see my doctor, because I know he's going to spend somewhere between 15 and 30 minutes with me every single time I go. And I love that.
Then you have a great provider, because
I do.
usually happen like that.
And, the difference between Jack's provider, who I know about, and similar to what we do here, versus, perhaps most physicians out there, is besides the telemedicine aspect, the other thing we do differently is we're not in the insurance model. We're doing what's called concierge care, or you might hear it called direct care. But we have made the intentional decision for our patients' benefit not to accept insurance. And sometimes patients don't understand that. They say, wait, I have this insurance and, that pays for everything. And yes, it pays for everything, but you get what they pay for. And what they pay for is typically going to be a 15-minute visit, 10 minutes of which the doctor needs to dedicate to doing the paperwork to make sure they get paid for that visit. And it leaves you with a very minimal interaction and restrictions on tests and other things. And so, we've made the decision not to take insurance. That allows us to have, usually 1 hour appointments with patients. And that's our standard appointment time here in the practice. And, and then we get the testing that we think is indicated for the patient, as opposed to the testing that the insurance will allow us to do.
And that's what I love, right? I still work in an insurance model. Yes, I have to see a patient every 15 minutes. And it makes it really hard, especially when you're trying to troubleshoot with a patient and I now have another patient waiting, and I still have to chart on this patient, and it snowballs. And that's why we end up being late to see people because it snowballs. And it's very stressful on the provider, because, you're trying, and I'm still trying to troubleshoot or talk. And I like to be able to take the time to listen to the patients, which I think that doesn't really happen anymore, because, you don't have time. So the doctor will come in and see you, and in 7 minutes he's out of there, and he's okay, what's the thing? And I've even had patients tell me they go to see their doctor and they tell them that you can only pick one thing that's wrong with you. I don't care if you have 5 things wrong with you while you're here, you can pick one. That's all the time I have. And I've had patients tell me that, and it's very sad, because they have 5 things. Why should they have to make another appointment and come back? But the doctors don't have the time, because their schedules are so booked, because insurance dictates care, and it dictates reimbursement. So it's, yes, people have insurance, but it's really, you only need insurance for catastrophic, because it's just not giving you much of anything either. Is it really helping you? But that's just my personal opinion.
You're not alone in that particular opinion. Oh, man. Phil, I approve. I mean, I know you didn't ask my opinion, but
yeah,
I think you got a good one.
No, I think this is, I know that we have, and been very excited to have Lisa joining the team. And, she is now actively seeing patients as part of the practice. And like I said, it's going to allow us to continue to grow upon what we've been doing here, at Ovadia Heart Health. And we're very excited to have her. Lisa, why don't you, I guess, just talk a little bit more about, where you see your career going from here? What does the future look like for you? What would you like to see, in terms of you personally, but also maybe the professional environment around us, as to what you're hopeful for about the future?
Oh, I'm pretty sure we're going to keep growing. So that's really exciting. I think what I really like about it is it's much more of a passion for me. So if you're really following something that you're passionate about, I'm not really doing work. Yes, I'm working, but it's different, because I love I've always wanted to educate. I enjoy that part. So I like getting people to really understand how things really work, and not just saying, oh, here's a pill for this, here's a pill for that. Nothing makes me shudder more when I see young people on 10, 13 medicines a day, just because we've been conditioned that there's a pill for everything. But my vision for Ovadia Heart Health is really to add more, providers as we grow. I just see it growing because more people are really like, hey, I've just noticed more people are looking towards prevention. And so now I think it's in the realm of, especially when it comes to heart health, because I'm telling you, I've seen 20 and 30-year-olds, in the CCU having heart attacks. And, it shouldn't be like that. These people are in the prime of their life. They shouldn't be thinking, oh, I'm going to have a heart attack, right? They should be like, hey, just living it up, not, healthfully. Let's get that. Healthfully should be living it up healthily. But, being able to just help more and more people. So I just really see, because it's such an awesome team. Everybody's passionate. Everybody wants to grow. I mean, it's been a joy to really be here just because everybody is on the same page. It doesn't matter which part of the team you're talking to. Everybody has the same passion and desire to help people and to get them healthy. But I just see that it's going to keep booming and growing, and we're going to add more and more providers that can help grow it. And I just think it's great.
Well, Phil, this is the point where we normally say, tell us how folks get a hold of you if they want to know more.
That's Dr. Ovadia.
Yeah. People should go to ovadiahearthealth.com and hit the button that says talk to us. You can also go to ifixhearts.com, which kind of covers more of our educational programs and coaching, but there's a talk to us button there as well. And that's the best way to have a conversation with us about what the best way that we can help you, because we do have a lot of different ways that we work with people these days. And the goal is to kind of match up how best we can meet your needs. But we're excited. I'm excited to be able to say we have room to take more patients into the practice, because prior to hiring Lisa, we were kind of at capacity. But I'm pretty sure that Lisa's going to be very busy very quickly. She already is. And there's just a big demand out there. Come join us on this mission.
Yeah. Oh, Lisa, it's good to meet you. I'm sure we'll cross paths again, probably in the not too distant future.
Okay, very nice to meet you, Jack. So thank you guys so much for having me.
This has been Lisa Simmons, the first of I'm sure many nurse practitioners that are healthcare providers at Ovadia Heart Health. Thanks for joining us. This has been the Stay Off My Operating Table podcast with Dr. Philip Ovadia. We will talk to you guys next time.
Chances are you wouldn't be listening to this podcast if you didn't need to change your life and get healthier. So take action right now. Book a call with Dr. Ovadia's team. One small step in the right direction is all it takes to get started. Contact us at ifixhearts.com/talk. That's ifixhearts.com/talk.